Good morning, everyone. Thank you for coming. I'm disappointed there's no students here, but that's all right. So today we'll be talking about FemoroAcetabular Impingement and the labrum of the acetabulum. And what does that mean for us? So just a brief overview. It's a difficult topic, obviously, because a lot of the evidence and theories about this are just emerging, even though the concepts have certainly been around for at least 20 years. We'll talk just a little bit about the basics of FAI and the labrum. We'll talk about evaluating, spend a bit of time specifically on the radiology, and then we'll go into the management, how we treat these. And then we can open it up for discussion because I think there's a lot to be discussed in this topic. So the labrum of the hip is a cartilaginous structure that it sits on the outside. It's a continuation of the acetabular cartilage outside of the rim of the acetabulum. So this is a cross-section of the acetabulum. And you can see here, this is what the labrum is. And it increases the coverage of the femoral head by up to 22%. And then it's a fibrocartilaginous structure on the articular side, and it's mainly type 1 and type 3 collagen on this, which is the capsular side. So there's a lot to know about it. It's similar to the labrum of the shoulder. It's primarily avascular, but it's loaded with nerve endings. So both proprioceptive as well as nociceptive. So it feels pain and helps us know where the hip is. And the majority of the blood supply, the best blood supply, is right here at the acetabular labral junction. And that, just like a meniscus in a knee, is important when we're repairing it. So it's circumferential around the hip cartilage and is in continuation with the transverse acetabular ligament. And its two main functions are, one is it provides a seal for the central compartment of the hip, which is the ball and socket part of the joint. And that resists flow of the synovial fluid out of the hip joint during motion. And that becomes very important with regards to having a stable fluid level around the hip. So when weight bearing, it contributes to even distribution of forces. It helps provide nutrition to the chondrocytes so that when you do walk on it and load, that fluid isn't being extravagated outside of the central compartment of the hip. And it also resists distraction. It helps create a negative pressure. So when there is distraction on the femoral head in the acetabulum, it helps keep the head in that acetabulum. So is very important for stability of the hip. And this is just based on some cadaver studies. And this is looking at the resistance to rotation. So the amount of force required, normalized torque here on the left-hand side, compared to the amount of force of axial loading. So 700 newtons is going to be, that's the force of the average body weight of a 70-kilo man. And so what they did is they measured it on cadavers with intact labrum, and then on patients or cadavers where they surgically torn the labrum. And you can see on the bottom, these ones with the intact labrum required, they had less force resisting rotation. So if you tear the labrum, you actually increase the amount of force required to move. So it creates friction within the hip. So it increases the loads going through that cartilage of the hip. So it seems to be the labrum is protective of forces on the hip. It helps it to have a less friction on the hip when it's moving. And then we'll get into FemoroAcetabular Impingement because we'll kind of bring everything together towards the end. So there's two types of FAI. The main type is cam impingement, and cam is a Dutch word for the word caul. That's where it comes from. And then that's where the main lesion is located on the neck of the femur. And we'll show you some pictures of that in a second. And then the next is a pincer impingement, and that comes from a French word to pince, we all know about pincer grip in the hand, so it's similar kind of idea. And the lesion is on the acetabular side. And then, like in anything, you can always put the two of them together. So just going through this is what my hip probably looks like. This is James Churchill's hip. You can see this extra bit of bone here on the femoral neck, and that's called a cam lesion. And then Scotty getting in and out of his Porsche, he's had a bit of pincer type extra bit of bone has grown here on the acetabulum. So you can see as the hip rotates around, this bit of bone is going to come into contact with the acetabulum and create an impingement. And this little triangle here being the labrum is going to get squashed and compressed. And so cam lesions lead to also labral pathology. So they're very, very closely intertwined. And then same with the pincer lesion, as the femoral neck comes around, the extra overhanging acetabulum will come in contact with the neck of the femur early, and then that will create an impingement and forces that will try to distract the hip and can start loading down on the opposite side. And then if you put the two of them together, it's obviously even worse. So looking at these patients who come in with normally a mixed picture of labral pathology or femoral acetabular impingement. So obviously important is the history. We need to get an idea of where the pain is, and it's traditionally, obviously, hip pain comes from the groin. And so we also have to get an idea of when is the pain come on. Does it come on when they're spending long times in a chair in the flexed position, which would be more consistent with kind of an impingement picture, versus are they getting pain after long periods on their feet and things like that? Or is it pain activities, certainly in athletes? Is it in specific activities, kicking activities? Obviously, it's all the rage at the moment in the AFL. And then you have to get an idea of where the limited range of motion is, and clinical examination is important. We'll take a bit of a look at that in a second. So this is just some diagrams of the clinical exam to look for femoral acetabular impingement. If you put them in the flexed adducted position and then forcibly internally rotate, and that creates pain, that is a sign of either labral pathology or femoral acetabular impingement. And then this picture in the middle is talking about when someone flexes their hip up and they cannot stop going into external rotation. That can also be a sign of femoral acetabular impingement. And then this is more for anterior impingement. Looking for posterior impingement, you can extend the hip and externally rotate, and then that will bring in any lesions, cam lesions or pincer lesions of the posterior acetabulum, and that can be a sign of posterior impingement. I thought this would be useful, especially for the residents and junior registrars, going through just how we take the x-rays and how we get those proper views of the femur, because I think we all know we send them down and we get some terrible views when they come back. So this is your standard AP pelvis, which we're probably very familiar with. Looking at a cross-table lateral, this is how it's taken. So the x-ray beam is taken from here in the corner and shot across the table with the receiving tray or the film cassette being at 45 degrees to the patient, with the other hip removed out of the way. So these are the other views that are particularly useful for looking for femoral acetabular impingement. There's a 45-degree Dunn view where the hip is flexed to 45 degrees and adducted to about 20 degrees, and then you take the x-ray is taken in an AP form with regards to the pelvis itself, and that gives us a nice view of the femoral neck and taking out the trochanters out of the way, so it gives you a good profile of the neck. And then you can extend that to a 90-degree Dunn view, which obviously the hip is flexed to 90 degrees, and again 20 degrees of abduction. The frog leg lateral, obviously used a lot in skiffy or Sufi, depending on what state you're in. So the hips flex to 90 degrees like a frog, and then it's taken in the AP forward. And this is a faux lateral, which you can see here is having a look at this hip here. And they're standard, they're 65 degrees to the film. And then the other leg is adducted to about 20 degrees. And this takes out the pelvis and gives you a good view of the femoral head-neck junction. So now, when we come into diagnosing FAI, a lot of it's been spent on the finer points of X-ray. So this is a normal hip X-ray. Things to note, this is acetabular coverage. And some of the important things here is the anterior wall of the acetabulum and the posterior wall of the acetabulum. All right, and we'll come to those here. And this here is epiphyseal scar. So, in a normal, taking a look at the normal hip, the anterior wall is medial to the posterior wall, and they both converge at the apex of the acetabulum, the superior apex. So here's a good X-ray view of a cam lesion. So as you can see, there's an excess amount of bone at the head-neck junction, and then that can lead to impingement. And here, as we were talking about the acetabular walls, this is what's known as the crossover sign. So the anterior wall starts more lateral than the posterior wall and comes across. And the posterior wall starting more medial and then crosses over. And this is a sign of acetabular retroversion. And this is a sign that is suggestive that femoroacetabular impingement can be present. So this patient has bilateral crossover signs. So this is suggestive that if this patient does have pain, continue to look better views for FAI. And here are some more secondary radiographic signs. This here is some calcified labrum. So the consistent impingement will cause stress and can cause calcification of the labrum. And then more with, this is a mixed picture. You can see the cam lesion and a pincer lesion here. You can have excess bits of bone, or these pincer lesions can fracture off. So these are all radiographic signs of FAI. So certainly MRI with regards to investigating the labrum is the gold standard. And here you can see some labral pathology, certainly high signal uptake in the labrum, in the superior aspect of the labrum. So if you're looking at, if you need to investigate where the labral tears are, obviously MRI is the best. Certainly at the COE earlier this year, they talked about trying to get the 3 Tesla, so send them to 3 Tesla MRIs because the imaging is so much better nowadays. The vision is better. I think Mr. Trump trying to smile at me. Probably the gold standard is arthroscopy, but as far as imaging, MRI is very good. And we also need to remember that CT plays an important role with regards to defining the bony anatomy. And certainly that there is a trend among some hip arthroscopists to have routine CT scans as well as MRIs. Because the MRI doesn't give us such a great picture. And this is important for preoperative planning. So these are just some arthroscopic pictures of labral pathology. So remember I was talking about at the acetabular labral junction is the best vascularized. So when it tears at that junction, these are very amenable to repair, or it can be degenerative tears in the outer substance, which are not so amenable to repair. So now, getting into the whole picture. So FAI, we know leads to a variety of different pathologies. It can cause this this consistent banging and in contact with the labrum can cause inflammation, can cause tearing. This tearing can then lead to loss of function of the hip. It can increase loads going through the hip cartilage due to extravagation of the synovial fluid. So this is then suggested to be the start of the osteoarthritic process. And how this leads to that is very interesting and is obviously a growing topic. So when we look at management, we always consider operative and non-operative and operative techniques. So in the young patient, probably the non-elite athletes, physiotherapy is obviously the mainstay of non-operative therapy. Trying to recruit your accessory stabilizers, recruit piriformis, glute medius, glute minimus to help stabilize and strengthen the hip. As we said, this can lead to a certain level of instability, so trying to reduce these episodes of instability can certainly reduce pain. Intra-articular injections, certainly with regards to the labral pathology or these cam lesions, they're not going to reverse this process in any way, but they are going to be used for pain relief. But there's not a lot of evidence with regards to using any kind of injections, PRP injections or steroid injections, to what the overall long-term outcome is. So now I'll briefly go through hip arthroscopy, and we'll just talk about the extreme of surgical dislocation, which for a long time was the gold standard in the mid-2000s, but now with the development and the increased better techniques of hip arthroscopy is becoming less prevalent. So this was more for the students. Just for those of you who haven't seen any hip arthroscopy, it's generally done on a hip, on a traction table, and that's required so that we can get the distraction of the hip. Unlike the knee or other joints, it's difficult to access with regards to the space, so the traction table is required. And using fluoroscopic guidance, the guide wire is passed, the hip is insufflated, and once under II, we're happy that we're in the joint. You can then use a Seldinger technique to put your portals in through your guide wire. So the different things that we can do during hip arthroscopy. So this is a patient treated at the Western not long ago who had a cam lesion. And then so you can do an osteectomy of that cam lesion, resecting the cam lesion. So now you see the profile has been restored to closer to normal. And then this will hopefully reduce the amount of cam impingement, reduce that amount of impingement, therefore reduce the stress on the labrum, and reduce the loads on the joint and restore function. Here's some arthroscopic photos of, here's a cam lesion that has been, after it's been resected. This is looking at a labral tear, so here's the acetabular, and on the rim of the acetabulum, and then that's been repaired with suture anchors. And this is interesting. Going back to the labrum, I was reading about some cadaveric studies in which they went on to tear the labrum, and as I said, the function of the labrum was lost. It increased the instability of the hip, and then they went on to repair these labrum in the cadavers, and then went on to test them again. And there seemed to be a restoration of function with repair of the labrum. So that's quite important. The evidence for certainly this repairing them is going to improve pain, and we know there's evidence short-term follow-up in 2 and 3 years that pain is improved following labral repair. But with regards to hip function, so we've done these cadaveric studies that show hip function is going to be improved. So hopefully in the long term we'll show that as you repair the labrum, it's also going to be a preventative thing with regards to the development of arthritis. But I think that this is where our information is going to lead in the long term. And then the question is, if some of these tears are not amenable to repair, certainly they'll have to be debrided, and that's a matter of pain and proprioception. So we're trying to remove symptoms of pain, but whether that's actually going to do anything in the long term, or whether it's going to speed up the process of osteoarthritis, that's something else that we do. So these are some of the other commonly found incidences. Is this delamination of the articular cartilage at the labral acetabular junction. And this is another reason why it's strongly believed that FAI, impingement, is leading to osteoarthritis, because it's very common to find this delamination of the articular surface right at the junction. So as this delaminates, and if it's not dealt with, will continue to delaminate, leading to loss of articular cartilage right in the weight-bearing zone, and then leading on towards arthritis. So there's a variety of different surgical options. Microfracture, like is done in any other joint, can be done. You can also put in fiber and glue, trying to stimulate this healing process to get the articular cartilage to heal back down to the acetabular wall. And certainly there is a lot of anecdotal evidence of people doing this in repeat scopes down the track and showing that this unstable flaps do become stable in time after these procedures. Or if there is articular loss, microfracture can be done just in the articular loss region, and similar to knees or hips, hoping for that fibrocartilage growing. There's again lots of small papers talking about good coverage rates following microfracture. And then finally, we'll get into the idea of surgical dislocation with better knowledge of the vasculature of the head. This is a bone preserving procedure, so we're trying to avoid any damage to the blood vessels to the head of the femur, which we know are very important with all the treatment of knobs. So treating them in younger patients. So Gantz out of the U.S. has developed, this is trochanteric osteotomy, in which this is looking at the hip from a lateral position, a lateral approach. There's a trochanteric osteotomy from the tip of the trochanter to about where the vastus lateralis insertion, and then so we leave the attachment of gluteus medius and gluteus minimus, and then that is reflected anteriorly, and that should give us access straight to the hip joint. And then there's what they call a lazy S incision, and then that can be made to help dislocate the head without having threatening to the blood supply of the head. And this allows for treatment of these same bony lesions. And it's found that some people have done this as a primary position because of the difficulty and the risks associated with hip arthroscopy. Or certainly now it's being done by some surgeons who have tried hip arthroscopy on multiple occasions without a good result. Still in the young patient trying to preserve this hip before leading on to any form of arthroplasty. There's a series of reports of about 20 to 40 patients and showing good results in up to 10 years, but whether that's long enough to, and this is a very invasive procedure, to think that this is worth doing is debatable. So I think that's one of the problems with this whole topic is that there's a lot of small studies. There's not a lot of great review articles out there encompassing all of this information, and will continue to grow. But certainly this is something that we need to know more and more about in the coming years. So I'm going to open this up to discussion now, because I think that there's a lot to talk about, and not a lot that I can say with confidence with my limited experience of 2 hip arthroscopies, which I've seen in the last week. So I think it's important to know that the labrum has 2 functions. One is it helps resist distraction of the hip, as well as it's providing a nice negative pressure and seal in the hip, so allow in the central compartment of the hip. We need to know that there are 2 causes of femoroacetabular impingement, these cam lesions and these pincer lesions, and then they can be a mixed picture, and that leads on to labral pathology, to articular delamination, and is certainly clearly a predisposing factor to osteoarthritis. There's a growing evidence of hip arthroscopy. Certainly it relieves pain. What the long-term outcomes with regards to preserving joint, we will certainly see, I believe, in my career. And then two of the problems that we didn't talk about with regards to the studies as well is there's no good outcome measures. All of our outcome measures are really designed for osteoarthritis, for end-stage osteoarthritis. So this is a disease that mainly afflicts people, young adults, when we aren't going to consider hip arthroplasty. So there's no good outcome measures at this stage, and certainly everyone is waiting for Fong-Tran to develop the best one. But that will come in time, and then the long-term results are still evolving. So I'd just like to open it up to anybody's